Vancouver, and he was in the middle of planning this conference when he passed away, and we miss him very much. This lecture is dedicated to him.
Thank you very much, Maureen. It's an honor and a sad thing for me to be here tonight, and one of the reasons because I started to work with Barry on the board of CNET when basically passed. So I feel very honored, but at the same time, I feel very saddened. What I thought I would do tonight is basically try to introduce you to the new concept in medicine, which is called personalized medicine. We in medicine have our own lingo, our own technical term, and at times it's not necessarily easy to understand. So what I'd like to do is try to place the neuroendocrine tumor a disease into personalized medicine. So I'm going to ask those of you who are very well versed into the field your indulgence, because I'm not going to go too much in depth into the knowledge which is currently available in terms of neuroendocrine tumor disease. And we are foremost a physician. And the problem is that with the amount of technology that we have available today, at times we just forget that we are foremost physician, human being, dealing with other human beings. So I always like to start with reminding people the definition of medicine. And as you know, medicine has been traditionally been regarded as both an art and a science. And the term came from the Latin ars medicina, meaning the art of healing. And if we expand a little bit, medicine is really the practice of maintaining and restoring human health through the study, diagnosis, and treatment of patients whose death is the discipline ultimate concern to avert. I think if we follow this principle and get back to the source, we'll realize that any technology that we have available today should only help us to carry our mission. So in the 21st century, we practice what people call empirical medicine, what I call symptomatic medicine. If you remember, and it's still happening today, unfortunately, is that you would visit your doctor, you would explain what your symptoms are, he would recommend a few tests. The test would come back to him, and then he would recommend a treatment, and he would send you back home and ask you to come back in a week, 3 weeks, 3 months, depending on what the disease was. This is clearly and typically symptomatic medicine, and that's the pre-genomic era. We have gone a long way over the past 25 years, and one of the major outcomes of the Human Genome Project and the Personalized Genome Project is that we have now a very good understanding, I should say a clearer understanding, of the sequence of events which leads to patient symptoms. And by the time we see the patient, we tackle the symptoms, the disease has progressed quite a bit. And in this era of DNA, we probably can characterize most disease, not all of them, under the form of genomic abnormalities. And it cascades down, that's on your left of your slide, it cascades down basically from genomic abnormality, genetic level, to basically patient symptoms. And the later you make the diagnosis of disease, the more difficult it is to treat the disease. So ideally, you want to detect the disease before it's present, before it manifests itself, and you want to do preventive medicine. We are in an era of nanotechnology, and this slide, this cartoon is actually from the Science magazine 2 years ago, 3 years ago, And 2 years ago, it was predicted that by 2020, it would cost $1,000 to have your genome being sequenced. For those of you who have access to PET or are aware of PET, and Canada is definitely a little bit of a struggle, but in 2003, when I was practicing at the Cleveland Clinic, we were charging $4,600 for a PET scan. $4,600. We would not collect that. That's again with the insurance company, but still we would collect about $1,000. So for $1,000 by 2020, maybe earlier, it's going to cost $1,000 to tell you if you're susceptible to some type of disease, if you could develop the disease, if you have some type of disease. So that's pretty competitive in terms of tool to take care of patients. So we can dream of a world where basically a patient would come with some symptoms and you run, or even before the patient develops symptoms, you run a genomic profile. And based on the genomic profile, you're going to take the appropriate actions in order to prevent the disease. This is the domain and the area of molecular diagnostic. Sylvia is here. I didn't get a chance to talk to her, but I am a firm believer in molecular pathology. I think she alluded to that this morning, and I can wait to see this happening because I think finally we're going to have a very good tool, not only to diagnose, but to give a prognosis and also to refine our treatment. So Sylvia, I'm a firm believer of molecular pathology. Now, most of you are very familiar with the BRCA1 and BRCA2 gene. It was publicized quite a bit. And it's very useful to know that when you have a BRCA1 and BRCA2 gene, which are expressed, which have their mutations, basically you have a 5-time increase to get breast cancer, be it male or female, doesn't make much of a difference. And when you have those genes which are basically expressed, and when I'm saying expressed, I'll get back to that in a few minutes, you have a 10-time increase in getting ovarian cancer. So we're finally a very good predictor of developing a disease. And then it's up basically to the healthcare system and the patient to decide if they want to be preventive. Some women are now electing to have a mastectomy if they have coming from a family which have a heavy history of breast cancer and are carrying those genes. Now, in terms of the neuroendocrine tumor and genetic syndrome, I think that we also have a very good knowledge, and it was described at length this morning, in terms of familial and genetic disposition to develop all kind of neuroendocrine tumor. I think it was also explained very nicely this morning that it's a patchwork, non-single size fits all. But I think that the knowledge is definitely coming together in terms of the genetic abnormality of neuroendocrine tumor, be it MEN1, be it VHL, or being tuberous sclerosis, or other type of neuroendocrine tumor. I think the genomic abnormalities are pretty well characterized. I'm not aware of any lab running those tests in a routine basis at this point in time, but maybe I have to have a chat with Sylvia, and she can pinpoint to me, or she can orient me a little bit better in terms of the world of pathology. So to make a long story short, I think that it's not that the knowledge isn't there. It's how to apply the knowledge that we have acquired by sequencing the genome, looking at neuroendocrine tumor and see which genomic abnormality were present, translate that at the clinical level. One notion that I want to introduce for those of you who are not directly versed into the medical field is the notions of oncogene, tumor suppressor gene, and in other words, what are the mechanisms which control cells growth? A cell grow, a cell divide. Your skin, for example, or probably the cell of your skin are probably not dividing, but if you cut your cell, the skin will repair itself. And there is a fair amount of mechanisms which are responsible for that. What I want you to remember tonight is basically there are essentially 4 mechanisms which are responsible for a cell to grow or to divide. One is basically related to signal, which ultimately reach the nucleus, which tell the cells you have to divide, you have to grow. Another set of signal are telling the cells by reaching the nucleus, well, stop dividing. It's not good to divide. For example, where the cell is becoming, has some alteration at the level of the nucleus, not good for a cell to divide. So that's called the growth suppressor signal, and I'll get back to that in a minute in a more technological wording. A third set of gene, which has been very much publicized in the press and the media, is a set of gene which decides that the cell is definitely damaged beyond repair and that the cells need to die. That's what we call a programmed cell death. That's the apoptotic program. Another set of gene which is being studied, and we're still learning a lot, is the set of genes which basically make that the cell is aging. And I think that there's a lot of information which come out of this in some very significant therapeutic applications might develop from that set of genes. So actually what's happening in the cells have a cycle, and based on those signal, based on the growth factor signal, based on the signal telling the cells not to divide, it's basically where the cells continue dividing or stop dividing. So the 2 set of genes which are responsible for the cells to divide are called oncogenes. And the other cell, the other signal, the other set of genes which are responsible for a cell not to divide are called tumor suppressor gene. The oncogenes are basically the growth factor. The tumor suppressor gene are the growth inhibitor of cell division. Now, for those of you who do not know what a gene is, the definition of a gene is very simple. It's actually a short piece of chromosome, short piece of DNA, which is responsible for the synthesis of protein. We have about in the body, it was thought when I started molecular biology 15 years ago, we thought that we have something like 100,000 genes responsible for the synthesis of a protein. In today's world, we believe that it's about 15 to 25. We're not entirely sure. But the way to see a cancer, the way to see a tumor is basically by the imbalance of the signal which tells the cell to divide and the signal which tells the cell not to divide. And let's suppose that you have a gene called an oncogene which promotes cell growth, cell division, and that signal is over-amplified. The cells will divide in an uncontrolled manner. And it's at the same time, you have those genes which are telling the cell stop dividing, which are knocked out. It's basically a two-hit aspect, a two-hit approach where basically the cell will grow in a totally uncontrolled manner. And in terms of neuroendocrine disease, those familial predisposition are pretty well known. Here, for example, what's called the MEN1 neoplasia is related to the gene called menin, which is actually a tumor suppressor gene. And when you have this type of cancer, basically the gene has been mutated. The protein coming from that gene doesn't carry its function. In terms of neuroendocrine tumor, as Sylvia and the others said this morning, the issue is much more loss of function than gaining overfunction. However, in MEN2 neoplasia, the issue is really that a receptor at the surface of the cell called the red tyrosine kinase receptor is basically overactivated constantly. So I hope that this demystifies for you a little bit the issue of tumor suppressors gene and oncogene. And I've listed here basically we like to represent things in one straight line. On the right side is basically the MEN1 gene and all the mutations, all the alterations which have been described so far. Somebody said this morning, not one patient is the same to the other. And the reason is exactly this. It's very difficult to tell when a patient develops a neuroendocrine tumor which part of the gene. First, you have to identify the type of gene which is mutated or altered, and which part of the gene is really mutated, which is the loss of the function. So there's numerous possible combinations. So there is nothing better, I think, in terms of personalization, is to look at some of these genes because everybody is really different. This is another slide showing the MEN2 type of neuroendocrine tumor, where basically the red TK receptor, which is at the level of the membrane, basically gets some alteration and constantly fires inside the cells and tells the cells you have to keep dividing. Now, over the past 20, 25 years, we have developed a tool. Remember the cascade of events which goes from genetic disease toward patient symptoms. And we have developed tools to better approach, to define, to characterize, to visualize those abnormalities. At the very bottom on the right is patient symptoms. And dealing with patient symptoms is basically patient clinical history. And I'm not too sure that all of us are doing a good job at that. Physical exam, stethoscope. And then you can go up the cascade, and going up the cascade is structural abnormality. That's CT, that's MR, that's ultrasound. But when you have a tumor which is visible, at times it's already too late. So we like to go up the cascade and get as close as possible to the genomic abnormality. So that's where basically nuclear medicine, that each of you have used at least once, is very useful. Nuclear medicine is by definition the exquisite tool to look at the function of tissue, particularly the function or the dysfunction of tumor. And then you go to biopsy, you look at protein assays, and ultimately you do a genomic profile. So that brings us to the second phase of a patient journey through a disease. We described the molecular diagnostic phase, and the next phase is the molecular imaging phase. So when we have predicted, when we have tried to prevent disease, but we have failed, we have to detect and pinpoint the disease. And that's where nuclear medicine and those radioisotopes, those famous radioisotopes, basically can play a major role. And basically, if you take the sequence here of molecular diagnostic and molecular imaging, you can easily, between molecular diagnostic and molecular imaging, plays very nicely the development of very specific probe based on genomic abnormality, based on phenotypic abnormality. We'll come back to that in a minute, and basically make sure that we can characterize very nicely those genomic abnormalities using nuclear medicine. You're all familiar with the somatostatin receptor business, and as you know, many neuroendocrine tumor overexpress the somatostatin receptor. That's the beauty of the system. When people ask me when molecular imaging really started, to me, it really started in the in the mid-'80s, in the late '80s, and I was privileged at the time to practice in Europe and witness basically the exponential growth of knowledge, essentially driven by Sandoz at the time and by the group of Rotterdam. I don't think Eric is in the room tonight, but you have seen him yesterday, and I'll talk about this 30 years experience almost tomorrow. So to me, molecular imaging really started with the octreotide. At the time, it was an octreotide actually. It was still somatostatin, and then they realized that the short life was not really amenable for significant result in imaging, so they shortened. They did some organic chemistry, and they were successful in showing up as a compound which has turned to be really very useful. Another compound which actually was dated, which came before the somatostatin business, was actually a compound which has to do with the adrenergic receptor. With the adrenaline, the noradrenaline receptor that each of us have in the body. And this compound is pretty simple. It can be labeled with iodine, 23, 31, 24, 25, and that turned out to be quite useful. What you need to know, too, is that like there is a somatostatin receptor, there is also a noradrenergic receptor. It's actually called a transporter. So by having the ability to label those receptor transporter, you can really characterize the tumor and apply eventually later on the same tool, the same compound, by loading those compounds with different type of isotope. Over the past basically 10 years, and thanks to our colleague in Europe, basically we have learned that it's possible to look at neuroendocrine tumor with positron emitter, with PET scan. FDG was mentioned this morning. It's not very useful because in order to be successful with FDG imaging, you need to have a very high turnover, metabolic turnover. Cells need to be very aggressive. So when a PET scan is positive for a neuroendocrine tumor with FDG, it's usually not a very good sign. In between, you can use a compound like fluorodopa, or you can use those somatostatin analog and label them with gallium-68. And I think that the experience of our colleague in Europe is not only positive, but it's very clear that we need to switch gear in North America in order to detect those tumors and consequently treat them a little bit better than what we have been able to do here in North America over the past 20-25 years. So let me take you to a definition of molecular imaging. There are multiple definitions of molecular imaging. I was part of a task force a few years ago with the RSNA, DSM, trying to come up with a definition. So molecular imaging is a new discipline that unites molecular biology and in vivo imaging, not in vitro, in vivo imaging. It enables the visualization of the cellular function and the follow-up of the molecular process in living organisms. So in other words, molecular imaging is essentially referring to looking at the molecular pathways that the cells is following, try to characterize the function of those molecular pathways and the dysfunction of those molecular pathways. The example that I love to show all the time is this one. This is a slide from Dana-Farber, and I was at Dana-Farber visiting my friend Dominique van den Abel when basically she was starting to look at patients with gastrointestinal stroma tumor, which can be very debilitating too. And they were at the time trying Gleevec, which is what's called a tyrosine kinase inhibitor on one of the receptors. And if you look on the right side of your slide, this is a PET FDG study. If you look at the baseline study, this is an FDG study of a patient with gastrointestinal stroma tumor with metastases all over the abdomen. And then you give one single pill of Gleevec, and after 24 hours, you have a fair amount of those metastases which do not take up any glucose any longer. And 7 days later, you have wiped out quite a bit of those tumors. It only takes 7 days, I should say 24 hours, to demonstrate the efficacy of one pill, but it takes 3 to 6 months for the anatomy of the tumor to shrink. So we have a wonderful tool and magnificent tool when we do metabolic imaging, when we do functional imaging, when we do molecular imaging using radioisotope. Now, one thing where we need to play catch up a little bit is the fact that our colleague doing therapy are playing with gene therapy, stem cell therapy. We need to be able to provide them with the imaging tool, non-invasive imaging tool, in order to assess their therapy. So what we are aiming at, what research labs are aiming at, is basically developing those tools to enable those physicians treating treating other patients, to evaluate the efficacy of their treatment much better. So we're almost at the end of the cycle here. We spoke about molecular diagnostic. We spoke about molecular imaging. Here comes molecular therapeutics. If you know what the pathways which derail cells from normal to become cancerous, you can design a little bit better those treatments. That's molecular therapy. It was mentioned this morning, the newest approach. I think Dr. Rowland went over that this morning. I think that's very exciting to have this new drug, so hopefully more will come. And at this point in time, it probably for quite a bit in combination or in isolation, we can also use those infamous in Canada, I should say, because they're not available, those DOTA something label, DOTA NOC, DOTA TOC, or whatever, labeled with yttrium or with lutetium. I was at Triumph this afternoon giving a lecture, and I'm in my naive thinking of molecular biology and nuclear medicine, my approach is that you potentially can label any drugs, be it somatostatin or any type of drugs that I showed you before with any type of isotope to get the best of both worlds and to get maximum efficacy. So what is molecular medicine? Well, molecular medicine aims at applying the genetic and molecular basis of diseases into each of the major specialties of medicine. There is not one single field in medicine which has not been affected by the Human Genome Project, the Personal Genome Project. So trying to place everything into context, molecular diagnostic and molecular imaging is basically everything on the left side of the clinical approach of medicine. And molecular medicine is the combination of these entire sequence from genomic abnormality down to patient symptoms. Now, you have probably read in the press or you have seen or people are mentioning personalized medicine. Well, I like to remind people that personalized medicine might be a new concept, but actually it's an old reality. And I like to remind people that personalized medicine starts in the physician's office when you have a one-to-one discussion with the patient. To me, it's personal, you might say personalized medicine. In today's world, the way people are calling personalized medicine is actually in a very different fashion. In 2006, then Senator Barack Obama introduced a bill to the Senate where basically he wanted to try to limit the side effect of medication. He wanted the pharmaceutical company to tailor the development of new drugs to the genomic profile of patient and their ability or inability to process those drugs. So in a more restrictive fashion, personalized medicine basically refers to patients' pharmacogenomics, looking at patients' ability to metabolize or not metabolize a drug and adjust those medicine, those treatment to patient genomic profile. In a wider definition, it essentially relates to the management of a patient's health based on its genetic pedigree, on its genome sequencing. Now, a step further, which we haven't really reached yet, is basically not only to consider patient genetic pedigree and genotype, but also to consider the environment around the patients. The best known is definitely the exposure to tobacco, to cigarettes, but there is other exposure which are not necessarily well known. And I think that in the future, personalized medicine will have to take that into consideration. So the way I think that medicine will be practiced, we're not there yet, but I think will be practiced. I'll probably be retired by the time we reach that level, but we need to aim at that, is basically to revisit a little bit our empirical model and based our practice on the patient genomic approach, a genomic characteristic, in order to, as I said in one of the slides, to be able to predict, to prevent, to pinpoint, and to treat and follow patients a little bit more specifically. Now, what I also, this is fancy and dandy, and it's great, and it's a great project, but I like to always to remind the residents that while we have made enormous progress in terms of characterizing disease in biomedicine, clinical medicine, surgery, and research, which are really the very bedrock of the medicine that we are practicing today. There's nothing else that is successful face-to-face relief of actual suffering resulting from the disease and injury. And I think that we would be foolish and kid ourselves if we believe that genomic medicine is the answer to everything. So I think the intangible application of human feeling and compassion needs to stay very present. And what I thought is that through the passing of Barry, I would take his passing and somewhat celebrate personalized medicine. We have no idea what Barry's genomic profile was, and didn't make much of a difference. We can really use it. So behind basically a genomic profile that we would get on a piece of paper, there's an individual, there's a human being. So my message tonight is that my fight is basically to make sure that the medical profession will keep taking into account that behind any genomic profile, any gene which makes the patient susceptible to something, there's a human being, there's an individual, there's a family, and Barry's family, I don't know if Deborah is in the room, she was here before. So I like to remind all of us that science is good, technology is fantastic, but after all, we are taking care of patients and individuals. Thank you very much.